I said that as of now, he's
Ahora está recién en la tele. Como estás en la presidencia.
I think Hello, good afternoon. Can you hear me? Does it? Hello? Yes. Thank you. Good hello and good afternoon, Excellencies, distinguished experts, ladies and gentlemen. It's my pleasure to welcome you on behalf of OHHR and our partners to this discussion on mental health, from rights to reality, with a focus on care, not custody, a human rights-based approach to mental health across the life course. My name is Khaled Hassin. I previously led OHHR's work on the right to health and will serve as secretary of the Intergovernmental Working Group on the Human Rights of Older Persons. And this event is co-organized. It worked fine, right?
Yes, we could hear you well.
Yes. So this event is co-organized with United for Global Mental Health and supported by partners, including, of course, the governments of Portugal and Brazil, the Global Mental Health Action Network, the Parliamentarians Network for Global Health, and UNICEF. Allow me a few opening remarks. Mental health lies at the core of the right to health, yet despite clear normative frameworks and repeated commitments, the reality for millions remains one of exclusion, neglect, and human rights violations. More than 1 in 10 persons globally need mental health services at any given time. However, services are often unavailable, inaccessible, or not compliant with minimum human rights standards. Many continue to face stigma, discrimination, violence, coercion, institutionalization, and denial of legal capacity. Over recent years, the Human Rights Council has provided important guidance, including through Resolution 52/12 and the comprehensive report presented at its 58th session in 2025. Most recently, in March 2026, the Council adopted Resolution 61/18, reaffirming the prioritization of the right to mental health and mandating OHHR to organize a global consultation in 2027. And this consultation will focus on 4 key elements: person-centered, recovery-oriented policies across sectors, deinstitutionalization and community inclusion, ending coercion or coercive practices, strengthening data systems, and integrating lived experience. It will inform a comprehensive report to be presented in March 2028, including a baseline assessment and recommendations for states and stakeholders on implementing a human rights-based approach to mental health. And I would like to thank Portugal and Portugal's leadership, along with Brazil's leadership in leading this initiative and resolution, because they have contributed to clarify minimum human rights requirements, standards, and the human rights-based approach required. Yet, a central challenge remains. How do we move from standards to implementation, from commitments to measurable change? Together with WHO, OHHR's guidance on mental health, human rights, and legislation provides practical direction, outlining minimum obligations and promising practices to align laws, policies, and services with human rights, and to promote a person-centered care across the life course. However, major gaps persist, particularly in data, evidence, and accountability. We lack sufficient disaggregated data on access to services, the use of coercive practices, and the experience of groups such as women, children, and older persons, including in crisis contexts. These contexts can be conflict or climate-induced. Without such data, violations remain invisible and progress cannot be measured. Especially the data gaps are aggravated through the use of large language models, AI, and automation. This said, a baseline assessment of the right to mental health, including human rights indicators, financing, and broader determinants is therefore essential. It would enable us to track progress, identify protection gaps, and strengthen accountability. This is not merely a technical exercise, it's about ensuring that policies reflect reality, resources are properly allocated, and the voice of those affected are meaningfully included. Today's discussion is an opportunity to bridge perspectives from law, policy, practice, and lived experience, and to identify concrete ways forward. Please allow me now to hand over to my colleague, Ali Hassanain.
Thank you so much, Khaled. And we'd also Can you hear me now? Oh, brilliant. Thank you so much. I'd like to start just by thanking, obviously, our co-sponsors, the governments of Brazil, Portugal, Guyana, also specifically the governments of Egypt and Pakistan, who've also joined us, and a few others in the room besides. We have also important partners like OHCHR and the WHO, many of whom are in the room today, UNICEF as well, UNAIDS, who have been championing mental health for many, many years in forums such as these, through the mental health resolution at the UN Human Rights Council. And I also am very, very grateful for all of the people in this room who are here to champion such important issues such as the interconnection of mental health and human rights, and specifically the issue of deinstitutionalization, which is one of the major reasons that we're gathered here today. And obviously, we've seen incredible work happen from the governments of Portugal and Brazil in particular in their national context, but also in the global context to advance this issue. We've seen a lot of progressive legislation and conversation in Egypt as well. We've seen WHO be at the forefront of a lot of guidance on the subject matter. OHCHR have been huge champions of this issue. So thank you so much to all of these partners, but also a big thank you to everyone in the room who has shown that they are here to advance and champion this issue and have been doing it in their capacity for many, many years. Really, this event is about the people at the end of the day who are most impacted when their human rights are not respected in mental health care. And we like to start by showing you a little video that goes into the details of what some of these people face on a daily basis. And also in doing so, to launch our Care Not Custody campaign, which we hope that all of you will be a part of.
Not authority. Their vulnerability is not synonymous to criminality.
I was sentenced to a diagnosis I couldn't.
I was sentenced to assault in a placement for him.
I was sentenced to seclusion without my consent.
I was sentenced to silence instead of being heard.
I'm Tiwa. I was detained for 14 months in a mental health hospital as a teenager. I lost many rights. I experienced things that nobody should.
I've witnessed what being in custody represents as a caregiver for my brother. Many times we found him heavily sedated, unable to speak, unable to tell us what had happened. And that uncertainty stays with you forever. It makes you question how much of that experience was truly care and how much of it was just coercion and control.
I experienced a lot of physical, psychological, and sexual abuse. I was sentenced to suffer when I hoped for healing, sentenced to hands that hit and never helped, sentenced to a system of abuse disguised as a system of care.
To me, care, not custody, means empathy, not authority.
Care, not custody, means saving people from unnecessary trauma.
Care, not custody, means the future. An optimistic one, filled with hope and growth.
You will hear from some of these people on the video in the room today as well. But before that, I'll hand back to Khaled for the first panel.
Thank you very much. And congratulations on this video, which is impressive. I would like now to briefly introduce our distinguished group of speakers. We are still waiting also His Excellency, the Honorable Minister, Dr. Frank Anthony. He's the Minister of Health of Guyana and has been practicing medicine in Guyana since 1993. Was also an adjunct professor in public health and served as Minister of Culture, Youth and Sports. Then a professor of psychiatry and mental health at Nova University Lisbon. Professor Miguel Xavier is also the national coordinator of mental health policy since 2022 and deputy director and president of the scientific council at Nova Medical School. Let me also turn to Ms. Helga Fogstad. She's the UNICEF Director of Health. Prior to her current function, she was the Executive Director of the Partnership for Maternal, Newborn and Child Health. Ms. Fogstad also held several roles at the Norwegian Agency for Development Cooperation, NORAD, including as the Director of the Department of Global Health, Education and Research. Online, we have Ms. Umuneana Rugege, currently serves as Head of Human Rights at UNAIDS, where she leads global strategies to integrate human rights into the HIV response. Prior to her function with UNAIDS, Ms. Rugege served as Executive Director of Section 27. And Ms. Tiwa Aveni is a youth mental health advocate from the UK and Nigeria, working as an expert by experience for mental health, not-for-profit organizations, child and adolescent mental health services, as well as the Global Mental Health Action Network. Without further ado, and while we are waiting for His Excellency the Honorable Minister, I would then, with your permission, hand over the floor to His Excellency and Professor Xavier. You have the floor.
Okay, can you listen to me well on the last rows? Yeah, okay. So thank you very much for the opportunity. Let me greet both chairmen and everyone in the room, dear colleagues. And before I say something, I would like to give you a 30 seconds overview about my work. I'm a psychiatrist, I'm professor of psychiatry in Lisbon, and I've been working in mental health reform for a long time. I've been working in several countries, mainly in South America and Central America, and in Europe also. And in each country I've worked, I've seen wonderful things and I've seen terrible things. Terrible, terrible things. And most of the terrible things were with patients. Okay? So I think this is quite an opportunity to address this topic of human rights, because in the end, this is a question of human rights. We think this is, sometimes we think this is a technical issue. It's not a technical issue. The technical is inside, but the issue is a issue of a broad concept of human rights. Second topic is to congratulate Brazil. Brazil is a wonderful country, as you know, a big and wonderful country. We are very proud to be with Brazil in this kind of doing those resolutions, which are very important. They are not, once again, technical papers, but are very important political papers. I use a lot these papers, these resolutions in my country, okay? Even if I think I'm convinced already in the Ministry of Health of my country, even so, this is very important. Why so? Because we think sometimes that most people think like us, and that going to the community is obvious, to close down psychiatric hospitals is obvious. But believe me, there are a lot of people that think differently, even young people, which is very strange, because I could accept that old people used to be in psychiatric hospitals were dealing badly with this situation. But my surprise is that young people, very keen on technology, on apps, on MRIs, on CAT scans, and so on, they still defend that we please keep some beds in psychiatric hospitals. We never know, we never know. Perhaps COVID is coming again, things like that. So after congratulating Brazil, it's good to have our brothers aboard. I'd like to say to you that from my experience, there are different levels of difficulty when we trying to change the mental health in a country. It's not very difficult to create mental health teams. It's very common, it's very sexy. We say, oh, we are going to the proximity with the population and so on. It's not so complicated. The complication arises when we try to, at first place, close down acute wards in psychiatric hospitals, acute wards. We struggled, and in the end, we can do it. But the last challenge is when you try to close down the chronic patients' wards. Because people that work for a long time in psychiatric hospital needs those patients there. Because if they move to another place, there is no motive, no reason for keep the psychiatric hospital open. And in my country, we are in our 4th attempt of mental health reform. I think this is going very well for the moment. We covered all the steps very easily. And now we are trying to finish the institutionalization. And we are facing problems now. And the problems start mostly in the professionals that work there. I'm sorry to say this. You will say this is not politically correct, but it's true. It's very difficult to convince people that are working in psychiatric hospitals for 20 years that we should close it. Because they say, oh, it's impossible. But why it's impossible? Well, because those guys are very ill. They are very dangerous. Think like that, okay? The truth is the opposite. Those persons, those professionals, they need to still continue to work in those places. And then they don't want to give up and to change their mind, because this is a problem to change their mind. So, to close the circle, I think that we still have a long way to go, a long way to go. But I think those kinds of resolutions and work between countries, it's very important to stress and to underline those topics and the importance of those topics. I finished what I'm saying that this is not science, this is just science, this is not just technique. This is a much broader concept of human rights, not mental rights, no, human rights of persons. And that's why I congratulate both of you for the opportunity to do this meeting. It's very important for all of us. Thank you very much.
Thank you very much. And it is more than encouraging and to have your words here as we go forward also with regard to the implementation of the resolution, the first baseline study. But let me hand over to Ms. Fogstad and your remarks. Please, the floor is yours.
Yeah, thank you very much. I've been asked to come with examples, and this is very encouraging of more focus. I just want to start with a key message, and that is that if we only focus on child survival, the Thrive agenda will become a survive agenda for the adolescent. And so therefore we have to focus on, and here is this pamphlet that you've all got. Less than 20% of mental health budgets are spent on primary and community interventions. And that it's an investment to do prevention, and it's an early detection and action. And this is something we must all be very aware of as human beings. So we need a survive, thrive agenda from the beginning. And that is really key, very important. So today, more than 1 in 7 adolescents aged 10 to 19 are estimated to live with mental health conditions globally. However, Underdiagnosis and stigma and weak data symptoms means that true burden is actually reported and not visible. So this is something that we need to pay a little attention to. In global UNICEF EU report poll, nearly a quarter of the 30,000 youth respondents selected managing stress and mental health is tough as their choice number one. So I think this is something that we need to pay more attention on, not only as a health issue, but a core human right obligation for states under international law, requiring states to progressively strengthen prevention, protection, and access to quality care across the life course. UNICEF's work supports states in meeting their binding human rights obligations under the CRC and CRPD by strengthening systems rather than delivering parallel services. So in 2025, UNICEF reached nearly 54 million children, adolescents, and caregivers with multi-sectoral maternal health and social support services in 130 countries, delivering through health, education, child protection, and community platforms. I must just say, if you reach it in health, it's a little too late. So you need to capture it in the other sectors. And this is where all ministers become health ministers, especially in mental health. And this is really critical. Recognizing the vast global mental health care gap and states' obligations to progressively realize the rights to child, UNICEF supports the adaptation, scale-up, and implementation of evidence-based approaches to enhance access to services. Through our joint program with WHO, we are supporting country-level action to deliver system change at scale. So since 2022, over 6 million young people have been reached with promotion and prevention programs. More than 10 million children and young people have access to improved quality mental health services each year. And 9 countries have been supported to establish national multi-sectoral coordination bodies. In North Macedonia, the joint program supported in the first ever National Action Plan for Children and Adolescent Mental Health. In Serbia, a government-led digital platform now reaches over 169 young people with digital mental health information, counseling, and referral support. We have got examples beyond the joint program initiative. Other positive examples are in Vietnam. UNICEF collaborated with the Ministry of Education and Training to promote human rights through enhanced participation in policy making, and in 2023 supported more than 2,400 adolescents to shape a national multi-sectoral policy dialogue on mental health and well-being. In Finland, UNICEF's Child-Friendly Cities initiative supports municipal governments to embed child rights within governance and local systems, focusing on creating safe, inclusive environments to promote mental health and systematically incorporate children's views in decision making. And in Chile, the National Policy on Child and Adolescent Mental Health 2023 established the intersectoral rights-based framework to guarantee the rights to mental health for all children and adolescents. The policy explicitly recognizes mental health within a broader child rights framework, such as non-discrimination, protection from violence, and participation, access to information, and the right to grow up in a family environment. So despite progress, the latest WHO Mental Health Atlas 2024 indicates still only 56% of countries have a child and adolescent mental health policy in place, far behind adult mental health policy coverages of 81%. The current need for greater prioritization and investment is in there. There is also need for scale up and systems. But the good news is that we have examples to build on and use and transfer from one country to another. So this is really something that is increasing, and more action is then needed. Thank you.
Thank you very much, Ms. Fogstad, for these insights and the concrete examples, solutions, pathways, illustrative examples. I would now try to hand over virtually to Ms. Umunyana Rugege.
Hello, everyone. I hope you can hear me. Great. Thank you, Chair and colleagues. It's really a privilege to join you for this session from Johannesburg, where I'm based. Let me start with what we have learned in over 4 decades of the HIV response, that communities and those most vulnerable must be at the center of the response, and that responses must be human rights-based. Leadership and lived experience keep responses grounded in social, economic, and political reality. Human rights, community leadership, and gender equality are all essential pillars of the Global AIDS Strategy 2026 to 2031. For people living with HIV, mental health is critical. It decides whether someone tests, whether they start treatment, whether they stay on it, and whether they live openly and safely. So we must continue to support community-led systems, even with limited resources. Peer outreach, harm reduction, legal aid, stigma reduction, and community-led monitoring are critical, but are often the first services to become fragile when funding is scarce and civic space shrinks. And indeed, we are facing organized and well-funded anti-rights campaigns that are translating into laws, administrative controls, and enforcement. And they determine whether people can access health services, whether communities can organize, and whether civil society can safely receive funding, communicate, and document human rights violations. And the recent Human Rights Resolution 61/18 adopted last month, the Council recognized the intersections between mental health and HIV, acknowledging that stigma, discrimination, violence, and abuse faced by people living with, affected by, and at risk of HIV have direct consequences on their mental health. And it also called for community leadership, evidence-based and human rights-based responses rather than custody, coercion, and control. This is important. People living with HIV experience depression and anxiety at rates 2 to 3 times higher than the general population. Surveys show that 1/3 of people who experience stigma and discrimination when seeking HIV services went on to interrupt or entirely stop their HIV treatment at some point. Internalized stigma is one of the strongest predicators of whether someone misses doses, drops out of care, or hides their status from a partner, family, and those that can support them. It is a quiet form of harm that is everywhere. The Global People Living with HIV Stigma Index shows that stigma cuts across different regions, ages, income levels, and shows that a staggering 86.4% of people living with HIV globally report experiencing internalized stigma. And as the UNAIDS 2025 Global AIDS Update report suggests, this is a psychological burden, and it undermines treatment prevention and keeps people from accessing treatment and care. So when we talk about mental health for people affected by HIV, this includes both clinical care and the conditions that make shame, stigma, and discrimination possible in the first place. In too many countries, mental health and HIV are still met with, amongst others, criminal sanctions, detention, forced treatment, and confinement. Key populations, such as people who use drugs, are locked in rehabilitation centers, sex workers are arrested, LGBTQ people are detained for who they are. People with psychological disabilities are placed in institutions without their consent. Criminalization and coercion do not improve mental health, they worsen it. they keep people from accessing the healthcare services that they need. Mental health challenges are also shaped by gender, race, HIV status, migration, class, and worsened where the law punishes rather than protects. So the evidence is really clear. Where laws protect rather than punish, health outcomes do improve. I'll hand back to you, Khalid. Thank you.
Thank you very much, and thank you for highlighting also the important linkages between HIV/AIDS and mental health. And yeah, the necessity, I would even say, to have an integrated, intersectional, human rights-based approach to address not only stigma, but also non-discrimination or ensure non-discrimination while addressing mental health rights as part of the right to health. Let me now turn to Ms. Aveni. You have the floor.
Okay, can everyone hear me okay? Okay, perfect. Good afternoon, everyone. It is a privilege to be present in this room and to have a voice in this crucial matter. I would like to speak a little bit about the recent resolution on human rights and mental health. In many ways, the resolution reflects what mental health and human rights advocates have been calling for many years. What stands out to me most in this resolution is that it frames mental health not only through a clinical lens, but fundamentally as a human rights issue. Another part of the resolution that particularly stood out to me was the emphasis on inherent dignity, individual autonomy, inclusion, and the freedom to make one's own choices. I think those principles are incredibly powerful because they stand in such direct contrast to the experiences many people continue to have within mental health systems globally. And I think that this is where implementation and accountability become so important. In both my lived and professional experience, there can often be a significant gap between rights being recognized on paper and those rights being consistently respected in practice. The real challenge now is ensuring that these principles meaningfully shape laws, services, clinical practice, and the everyday experiences of people accessing mental health support. I think people with lived experience should have a meaningful role in shaping mental health laws and policy reforms because we understand how these systems are actually experienced in practice. Too often, participation becomes symbolic rather than genuinely collaborative. People are invited to share personal experiences once decisions have already largely been made, rather than being involved in shaping the priorities, implementation, and accountability from the very beginning. And I really welcome the resolution's emphasis on meaningful participation because rights-based mental health reform cannot happen effectively without the involvement of the people most impacted by these systems. Thank you.
Thank you very much for sharing your appreciation of the resolution. And I think that's our shared challenge also, how to bring about implementation. I think this can probably only be conducted jointly if we join all together forces. And if you all agree, we will now open the floor for questions and comments. I would like to remind all speakers to be concise, keeping interventions brief. So, and would encourage now any questions, comments, please. Please.
Thank you so much for the opportunity. and I hope you can hear me clearly. So my name is Mohammed Hussein. I'm a medical doctor from South Africa. I'm so pleased to be here and to be part of the discussion on this very important issue when it comes to mental health. We're seeing it firsthand in my country. And of course, I can relate to the HIV and AIDS epidemic that was just touched on. So the question I wanted to ask in that, how do we practically transition our low and so the LMICs, how do we transition them from their custodial psychiatric systems towards a community-based approach, in that a community-based mental health care system, but also ensuring the continuity of care to our patients? How do we make that kind of transition? And perhaps a second one, if you have an appetite, to comment, is that what accountability measures should be in place for those member states who continue to permit the involuntary institutionalization of practices that actually contravene international healthcare standards? Thank you so much.
Thank you. Any other questions? Otherwise, I will hand over to the panel. Professor Xavier.
Well, there is a lot to say about your questions, but let me give you an example of what we've done. When we started this attempt of mental health reform, we've noticed that we had to change the laws entirely. The law regarding the organization of mental health services, the mental health law, which is related to human rights, and the law, special one for forensic patients, okay? And the first step that we've done was to include persons with experience and their families in the group that was drawing the law. And it made all the difference. So I'm pretty sure that if you don't do that, you will lose something, okay? And it's not very easy to accept that, because we professionals, we are much more keen on work between ourselves. And when you are drawing a mental health legislation, if you want to put change on it, you have to include persons with experience and their families. Otherwise, it's impossible. I strongly believe about that.
Thank you. Ms. Foxter?
Yeah. So I think it's a really good question, and it's an important one, because I think there is guidelines now that did not exist before, and they are explicit about how you not only take care of primary health care and capture that, and the investment of the primary level, and not only institutions, but also across sectors. So really a nurturing care framework in early childhood development is really important, and they are there. And I think that they are frameworks that are accountable and that can be used. And I think the parliaments and politicians are now increasingly being interested to understand how they can be used in the countries and to follow up. However, accountability is really important, and that's why if you want something to count, you have to count it. And in order to be able to count it, you have to have a declaration or a monitoring framework and a process that is important enough to really matter. And that's why all of these declarations are important, to really follow up on countries that are not really implementing and giving then actually power to truth to power.
Thank you very much. Ms. Umunyana Rugege, perhaps, if you have heard the question.
Yes, I heard the question. And I think it's really important to ensure justice as well. So those whose rights have been violated either by the state or by private actors, should have some recourse through mechanisms that exist in law. And these can be court proceedings, but also quasi-court proceedings. So, you can have outside of courts, you can have different kinds of processes, restorative processes that enable people to talk about their experiences and to have some outcome that can form the basis of experiencing justice. Because often people in these circumstances are the most marginalized, and they may not have the funds to go through expensive processes or afford lawyers, but they have to be processes in which they can participate and get justice for human rights violations. Thank you.
Thank you very much. Please, Sabine.
Thank you. In regards to the question about transitioning from hospitals to the community, I think that systems have created the challenge, and now we use the challenge to justify why we're not able to change things. So we've kept people institutionalized for many years, for so long that now they don't know how to live outside of these institutions. And then we use that to say, now we can't change things because they're going to be too unwell to be able to survive out of hospital. But we can't keep doing this for so long. We have to change it now and support people to live the life that people deserve in the community. Thank you.
Thank you. There are no further questions. I would, please, I didn't see. Sorry.
Oh, I saw him.
Thank you. Distinguished Chair, Excellencies and colleagues, I would like to share a little bit different perspective on that. My name is Jakub Biel. I'm speaking as a co-chair of UHC working group within Global Mental Health Action Network. So like having the perspective of universal health coverage, we can assume that universal health coverage and mental health is about ensuring that every person has an access to healthcare with dignity, without fear and financial hardship. So in mental health, that commitment remains very far from being fulfilled. From our perspective, like from UHC perspective, it still must mean dignity. It must mean rights, especially everything shall to be based on human rights. And across the world, millions of people are living without any possibility to access mental health services. So if we would like to implement care, not custody, we have to implement also the whole solution within universal health coverage. We do have people who are affected in conflict zones, humanitarian crises, displacement, living in poverty and fragile settings, people who are left without access literally to no healthcare at all, and mental health is not present also. So if universal health coverage and care, not custody, if that might be implemented, we have to exclude every single obstacle that may be met by those people. And we have to think of that in the sense that those people are not counted in thousands, they're counted in millions. So I would wish that like mental health is not only about those who are covered by social security number. Thank you.
Thank you. Please.
Thank you. I'm Odile Frank. I'm here on behalf of the American Psychological Association. I want to thank all the panelists for very thought-provoking presentations, but I have a specific question for Dr. Xavier. I'm very sensitive to the issue that you raised with regard to the reticence of the healthcare workers, the employees of psychiatric asylums, as we used to call them, the institutions where chronically people with chronic conditions were kept. And I'm wondering whether, to what extent there are opportunities for retraining, not only within the system, but perhaps outside of the system, to assist them in working in community health centers, for example, and whether those opportunities make any difference. Because it seems to me that what lies behind that is this fear of losing their jobs more than anything else. Thank you.
I think, well, I can talk from my experience mostly. When you give the opportunity to those health workers to work in another setting, they will change and they don't want to get backwards with no problem. And there is a lot of experiences like this at least across Europe. And we've done the same in our country, because we had in the past around 8 psychiatric hospitals, and we are closing the last 2. And those persons did not go to the unemployment. They start to work in community, and they like it a lot. Of course, if you tell me, all of them, no, there are always people that don't want to change the mindset. Because I think, in my opinion, this is a question of mindset. It's not a question of technique, of psychiatry. It's a question of mindset. So I think this is a kind of opportunity when you honestly say, we know that you are familiarized with this setting. There is another setting. Usually persons like to work like this. Try, at least try. And it works in most times. If you don't have this opening, I think it's very difficult. In my opinion, it's very difficult. For instance, if you don't, 30 seconds to another history, okay? I don't like very much written speeches. I do prefer histories. Around 15 years ago, I was working in one of the Baltic countries and trying to help the government to include these kind of new things, community and so on in mental health care. And they took me to psychiatric hospitals, the usual picture, around 1,000 beds, usual things. And I went to a ward of ladies, old ladies. The beds were collapsed to each other, so there was no space at all between the beds, okay? I was with a translator, a doctor that speak that language and English, and the guy said, do you like to ask something to the old ladies? And said, oh yes, how do you feel here? Do you like to live here? And he asked the question, he translated the question, and one of the ladies started to talk. And she talked around 4 minutes with no interruption. And in the end, almost shouting, okay? And after she finished, the guy, our colleague, asked me, do you want me to translate? Yeah, of course, given she talked about 4 minutes. Please. Very simple. She said that you are here to close the hospital. She said that if you close the hospital, she will sleep in the street. So she said in the end that you should return to your country. Okay? It was my experience. Shall I say that my colleague, was a devil? No, of course not. He worked there for a long time. He had no opportunity in their lifetime to experience nothing different. But these things exist, still exist. So I think, to be honest, that we should push to the right thing. We should be honest, but we shouldn't be naive. We cannot afford to be naive, in my opinion, to be honest. Thank you.
Thank you very much.
No, you're welcome.
I see one final question before we.
So I'm Saliha Hassan. I'm an emergency medicine doctor, and I am based in Cambridge, where I run a network examining healthcare in armed conflict. A couple of things I want to bring to you, if I may. I'm really pleased about this resolution, which contains member state commitments to align mental health laws and policies with a human rights approach. I just want to, if I may, give you some very personal practitioner perspectives that I've experienced over my years of working as an emergency medicine doctor. And also, some of that led to me actually doing the LLM in international human rights and humanitarian law, because I was so appalled by what I was seeing. In fact, that was a fantastic year, but also one of the most depressing, because I learned about the laws and I thought, what are we doing? The work has already been done, but we're not using them. So this is great to see this. The right to mental health is enshrined in law. We know that. The right to health is. Mental health has got to be an equal part of it. I work within settings where we have children, young adolescents who attend emergency departments in crisis. The practice for a number of years was to detain them in some facility until the child and adult mental health services arrived. And they were overstretched and it would take a long time. And I remember this, I remember the shifts myself. And to my horror, they would be taken to police cells. So care, not custody. It really resonated and it's flashed that all back to me. We did an audit in my hospital to see how many of these children were ending up in police cells and over what period of time. The numbers were shocking. So we worked internally within our hospital with a simple piece of research to push that up. And practices changed. And I'm now glad to say that resonated across the system. And I know that in the UK now, the government made an action that since 2017, you cannot detain young children and adolescents, whatever their crisis is within police cells. And we took the public with us on this. Programs were made on this. Public engagement. It's really important that public engagement is used as part of this. So one of my questions, what I'd like to ask is, how much are we drawing on research and the work of clinicians on the ground to feed into helping support this resolution, really have some teeth and make some actions? The other thing that I wanted to quickly mention was about, a colleague over there mentioned it, about the current climate of war. That's my area of work and focus, healthcare delivery in armed conflict settings. I know as a practitioner in those settings, mental health is secondary if they're present at all. We work with the physical, we work with NCDs, we work with physical trauma. Mental health doesn't even register. I'm sorry to say it doesn't until way, way down the line. And often when these people are refugees and asylum seekers, and then what do we do with them when they come to our countries? We detain them, we lock them up, we take away other rights. So the issue of the right to mental health, again, I ask, how are we examining that across other rights? The right to liberty, the right to family, the right to be free from torture. How are we bringing that into the work that we're doing with this resolution?
Thank you very much. Thank you. I would like to give for a final 30 seconds final remark to the panel. Would like to start with Ms. Fogstad.
I think the resolutions as well as the guidelines take as much experience and learning from the ground. If we do, if it's enough, I think it has to be a continuous effort, really. And one that we maybe open up to getting, it becomes an iterative process which capturing learning all the time. And there are a lot of opportunities because, as you all know, there has now been declarations and the NCD and mental health declaration, but also at the 63rd session of the Human Rights Council in September, the resolution of youth and human rights offers a chance to highlight mental health as a critical multi-sectoral issue, and the launch of the High Commissioner study on youth mental health presents an opportunity to center the voices, experiences, and rights of young people in global mental health discourse. And I just think it must be a cross-sectoral effort, because it can't be only at the asylums and mental health, and not call that any longer, but it's absolutely too late. We must be really preventive and do a cross-sectoral, and it has to start at early childhood development. It just has to, and then be recognizing that. And then these declarations that are there is consultations, and I think that these consultations are only as good as all the constituencies that we're able to bring in. But I think we now, with the digital era, it's been easier to capture voices and active practitioners like yourself. So I think that that's really important, and that's where we're going to actually continue it. Thank you.
Thank you. Final remark, Ms. Ayeni.
I think that it requires constant and consistent supervision. I think it's a good opportunity to try and get numerous countries to be on the same page. I think at the moment, mental health systems across the globe are so vastly different that it's so difficult for countries to be able to receive learnings from other countries and to be able to see what we're doing good and what we could be doing better. So I think that communication is also so important.
Thank you. Professor Xavier, final remark.
Well,
before we hand over
I
to...
will be forbidden to come to this meeting. Anyway. Well, after a long time working in this field, I think that a mental health system doesn't change from inside. Unless we have strong powers from outside, coming from the political areas, social areas, otherwise it's very difficult to change a mental health system from inside, okay? So I think that it's like a metaphor. It's like I move between this kind of meetings and meetings about psychiatry and mental things like more technical. And it's like two rivers flowing without contact. No contact at all. I think that our obligation is to start making some bridges between both rivers. This question is wonderful. And unless we can be successful in doing this kind of bridge, I think that those two rivers will continue to flow without contact, and it's a pity for all of us. Okay? That's what I think.
Thank you very much.
No, you're welcome.
With these words, I hand over to Ali Hassanein for the second panel.
Thank you so much, and thank you very much to the first panel for an incredible level of insight, and also to many people who spoke up. A quick round of applause for panel one, please. We're going to now move to more of a roundtable discussion. We are having equally brilliant, if not more so, panel for the second roundtable as well. It is my distinct pleasure to introduce to you Honorable Senator Amira Saber. She is the Secretary General, Human Rights and Social Solidarity Committee at the Parliament of Egypt. We have Dr. Marcello Kimati Diaz. He is the Director of the Department of Mental Health, Alcohol, and Other Drugs of the Ministry of Health of Brazil. We also have with us Dr. Safi Malik. He is the Senior Advisor to the Ministry of National Health Services, Regulation and Coordination, and also formerly served as its Director General for the Government of Pakistan. And we have with us Deborah Castell, who's the Director ad interim of the Department of Non-Communicable Diseases and Mental Health at the World Health Organization. We've just already touched upon quite extensively the issue of deinstitutionalization. I'm going to borrow the words of someone in this room that we met just yesterday. Mark, don't mind. There are actually, institutions are taking about 2/3 of the entire mental health budget up. So there can be no discussion on mental health without discussing the aspect of deinstitutionalization. And it is such an important issue because millions of people are involuntary institutionalized every year, and it needs to be addressed. With that in mind, let's start with our first set of questions. I will start with Dr. Marcello Kimati-Diaz. Dr. Marcello, we've briefly discussed the UN HRC mental health resolution. Brazil very kindly has co-chaired it along with Portugal. It emphasizes deinstitutionalization a lot as a prioritization. It's one of the few international resolutions that does. Why is it such an important issue for your government?
Good afternoon, and thank you very much for the invitation. You asked me two things in this paper. You asked me to say about this relationship between human rights and deinstitutionalization, and what the lessons Brazil learned in these 25 years or more or less about this process. About this the relationship between this institutionalization process and mental health, I believe the both are inseparable from guaranteeing of human rights from people with severe mental disorders. The model of care centering in the psychiatric hospital, and especially when you add to it compulsory hospitalizations, cause violations of right in a systematic way. Institutionalizations is related to social isolation, loss of relationship, and the process is becoming more and more profound. You said about our experience in this institutionalization. Most of people who lived in psychiatric hospitals, when leave the hospitals, couldn't cross a street by themselves, couldn't use a fork or a knife, and you lost everything in a psychiatric hospital, and it's absolutely impossible to say that process preserves human rights. So the relationship is associated. So about our lessons, it's very interesting to say that, because when you say about this institutionalization in Brazil, it's you have like a story you say and repeat, and there is a narrative very known. But when you talk about it to partners of another countries, you have to think actually what happened in Brazil these years. And I try to separate three main lessons about this. The first one, that is this institutionalization in both process, legal and policy orientated. I believe this part of legal things were discussed a lot here, but it's impossible to have a law, but you don't change all the health system. And we're talking about the process. You have to transfer the budget of health from the hospital to the another kind of health service. So, and about the law, it's important to say that includes changes of model health systems, and the law in Brazil, the reform of psychiatry law, it took 12 years in the Congress. So it's a long way. And when you took off the money from the hospitals, you have to put in another kinds of programs. We have the program De Volta para Casa, for instance, that means going back home. Benefits like 8,000 people who lived in psychiatric hospital for many years. And these programs combine housing and financial benefits for this. But it's important to say these benefits are not just, it must be must be interpreted like reparation, reparation policy. The second lesson is that the model based on psychiatry hospital is above all less expensive than the system based on community services. Is less expensive, but much more ethical and social costs are very, very high. And we have a lot of problems for many, many years. This institutionalization involves a creation of a large mental health system. It must be able to provide care based on what is particular to each individual. It requires a larger number of professionals, a larger structure, care strategies in crisis situations, and more qualified professionals. It's much more complicated to have a system based on community care and have a system who doesn't institutionalize the patient. I believe the third lesson is that the systems that replaces the psychiatry hospitals will always be in transformation. Issues related to mental health are sensitive to societal change, and the territorial base of these systems allow these transformations to be quickly identified. And these new demands are impossible to avoid and sometimes impossible to prevent. For example, one example is the problem related with gambling and betting, that was absolutely unpredictable 25 years ago when psychiatry reform in Brazil was approved. And the fourth lesson is the care models tend to be institutionalized. I mean, we live, for instance, today, one situation in Brazil, and when sometimes in some communities, 4 in 10 persons use antidepressants. This current trend toward the massification of psychiatric diagnosis is one example of this institutionalization. Scientific literature indicates that in Brazil sometimes we have 14 or 60% of individual in use of psychotropic medications. And of this, we have like half or 16% that becomes chronic users of antidepressants. And it's very difficult, don't understand this process like any kind of institutionalization. And it will always be more complex and expensive for a healthcare system to develop mental health policies that consider subjective cultural aspects as constitutive of mental suffering. But in Brazil, psychiatry reform increases a society perception of human rights in general. We believe the psychiatry reform changes the way the society understands human rights at all. And it's very important for us. Psychiatry reform is a good example how a policy can change the way people see human rights at all. Thanks very much, I think.
Thank you so much. We are now going to turn to Honorable Senator Amira Saber, who I understand also has to leave shortly after. Honorable Senator, Egypt has done some mental health legislative reforms recently. We're very curious to understand, as a parliamentarian, what are you doing to ensure mental health laws in Egypt continue to correspond with human rights and enable community-based mental health care?
Thank you so much, and I'm very glad to be among you today and leading this very important discussion. And it caught my attention what you're mentioning here, which are numbers that counts. 73% of countries have mental health laws that fail human rights standards. Actually, in Egypt, we have relatively one of the most advanced laws in the region, because it was back to 2009 when that law was released. And as a legislator, all the time, I care about the delivery, the same as I care about the legislative framework. And in a region like mine, where wars, conflicts, and immigration are key, I can't separate the discussion from the context. Because in countries like mine, actually Egypt is having millions of refugees coming from Gaza, coming from Syria, coming from Yemen, and they come with their traumas, and they come also with their burdens. That's let alone that this discussion couldn't be separated from how the economic situation and how the developments in today's world are leading to more numbers of people mentally suffering and psychologically unwell. This should be also coupled with a real increase in the budgeting and in the efficiency of the systems. So what I always call for, it's not just the laws are very important, but we write beautiful laws. I'm not talking about Egypt, I'm talking about everywhere else in the world. And here I also want to talk about my capacity as part of Unite Network. Unite is the biggest global network which is working with health, which is working with parliamentarians who are caring about health issues, and it comprises parliamentarians more than 550 from both chambers across 120 countries. I think this dialogue, I should take it also to Unite. We have a next summit in August, because I want to also to launch and tap on the mental health and the well-being of the parliamentarians and the policymakers themselves. Because this also is an issue which is under-tapped and which is extremely important. When you have a parliamentarian who is believing in the importance of the video which we have watched, and that justice and human rights applies as a cornerstone in all what's related to mental health as a right, not as a luxury. And this is the talk in my country. It's not a luxury that we have universal coverage or healthcare coverage from the government when it comes to mental health issues, especially with all such challenging conditions which I'm talking about. It was very alarming for me that the WHO Mental Health Atlas, the 2024, showed that mental health is still only 20% of the health budgets, 2% of the health budgets globally, unchanged since 2017. Exactly, I just missed the number. 2%. 2% is extremely alarming, extremely low, and this is global. So yes, I definitely wanted to say what's happening in my country, but also in the region which are classified as low-income countries. It's 4%, 4 cents per person per year, 4 cents per person per year dedicated for mental health. And even if this budget, which is the 2%, is allocated, talk to me about how this is reaching the rural areas, how the accessibility question is being applied. And I didn't yet talk also about the issue of how people suffering mental health are being labeled in their communities sometimes. So this is also adding layers of complexity to how it is. It should be, in what you're saying here, it should be a community approach other than isolation. And the community healthcare here, I don't recall that we do have a psychiatrist at the primary healthcare units. It is a right that when you are heavily suffering, you find the proper help which you deserve. And this translates to less crimes. This translates to communities that are suffering less tensions. This translates to more of understanding in today's world, where the logo and the sphere is full of misunderstandings, full of tension, full of individualism, other than understanding that there is no one safe until everyone is. And this also includes mental health, among which I mentioned the law, the law number 71 of 2009, which was released in Egypt. I was at the House, and now I am at the Senate. So also I always encourage that both chambers at any country talk to each other, because this issue needs like a deep dive, and we need also to think about eliminating the coercive practices, because this happens, and that the decision making is supported decision making within a legal framework from a rights-based approach. I'm now on the Committee of Human Rights, and it's rarely that this is seen as a basic human right. In contexts where poverty, where education are real challenges, sometimes mental health is seen as a luxury. This is something which I make sure is not happening, because it affects everyone else. You can't ask someone to deliver properly at any kind of work if they are not feeling the ability to do. You can't ask a student who is having issues, being bullied, suffering, to perform and get well education unless they can do it and they have the support that is requested. So I think also that awareness is a great component. So as parliamentarians, we should jump in when it comes to legislation, when it comes to asking the governments and holding them accountable, and most importantly, when it comes to the budget line. The budget line is something that should be translated to materialistic, actually, on the ground, materialistic, tangibly attained and tangibly seen in the primary health care, in the community support, in the hospitals, in the practices, because also even at custody, even if someone with mental health issue has been at custody, he should be treated properly, with the human rights framework being really applied as a core belief from all those who are dealing with the process, which needs also capacity building. Here comes again the budget line. How much is dedicated for capacitating the sphere? The sphere is the community, the sphere is the legal framework, the sphere is everyone who is touching point, in a sense, with someone who is suffering. Thank you so much.
Thank you so much. And while we can say that it may not currently be seen as a basic human rights issue, I do believe, Senator, that with people like yourselves in Parliament, we may increasingly start to see mental health as a major human rights issue, and hopefully also reflected in the budget lines. Thank you so much for that intervention. I will turn now to someone I'm personally a big fan of, and who has really fought the good fight for deinstitutionalization within WHO and outside of it for a very long time. Deborah, I have to ask, why is deinstitutionalization such a big issue for WHO? You are welcome to go off script as well.
Thank you. And yes, I think since we started the discussions, I'm looking at my talking points as I'm going through that, and I talk about and I'm debating. I don't know what I'm going to do. So some of us are less young in this room, and I was recalling that the first time I went to a psychiatric hospital was in 1986. Exactly 40 years ago. And I couldn't understand why people were living in the conditions they were living in. Very clearly described before by those who have managed to promote changes at home. So congratulations to you all, both of you. But I think that that moment marked, without me knowing, the career I will do. Because I ended up in a position that will allow me, perhaps, to have an influence. It takes time, right? Unfortunately, it takes time for reforms in a country like Portugal, right? And it took me 40 years to come to have a position in WHO where I'm almost proud to be launching, almost, it's not going to be on my time, but almost, the guidelines on deinstitutionalization. It is the essence, of course, for me, the most important topic, and the one I'm more passionate about, and I had the chance to work in many different countries and in many different settings and learning from the best in somewhere in the north of Italy, but also being in small, tiny islands or in bigger countries to learn how others have been doing it and what are the challenges and what are the opportunities. And there are so many opportunities to change the issue. But what I think it is important is that for WHO, we work around health, obviously, our priority, but then also the idea of strengthening health systems. Universal health coverage was mentioned before, right? So strengthening health system, if we translate that to mental health, we cannot, it's a fake to believe that we will strengthen any mental health if we don't tackle the institutions. Because it was mentioned before, we have 2%. If it was 20%, I was dancing on the table, I swear. 2% of the budget, the health budget, sorry, my jacket just fell with the emotion. 2% of the health budget goes to mental health, and from that, in many countries, 90% goes to psychiatric hospitals. Globally, we are talking about around 60, 70, but we don't have the numbers of all countries. So I am convinced that it's way higher than that. And that means that with 60, 70% goes to a psychiatric hospital that serves a few hundreds, a few thousand people, the rest of the population has to deal with whatever is available with 20%, 30% of the budget remaining for the services of the community. So there's no way that there's going to be a functioning mental health system unless we tackle institutions. And we work the institutionalization with all the challenges that entails. Because again, we have in the room 2 at least of the countries that have started this process 40 years ago, and they are still struggling to get there, right? Because it's not simple, it's complex, it's difficult, it's challenging, it touches so many different interests, as we heard, but there is no other way. Or we do that, or we do superficial work. We are nowadays, since COVID's time, perhaps more and more listening about a growing number of people young people with mental health conditions. What are we waiting for? So that they get worse and we send them to other institutions. If we don't change a system that is capable of absorbing and responding to the needs of everybody with a mental health issue in different ways and with different components of the system, then we will see a future in the next 40 years. I don't know if I will be there looking at it, but a system with even bigger institutions, because it's never going to be enough. So there is no other option. Or we do it, or we do it. Thank you.
Thank you, Deborah. That was very beautifully put. I will now hand the floor to Dr. Safi Malik. Dr. Safi, thank you so much for being here with us. We understand that Pakistan is now working to develop a new mental health policy. How can this policy serve as a catalyst for deinstitutionalization in your country?
Thank you very much for inviting me, and just would like to share the demographics and country status. So we are a low middle income country, 260 million population. Under 40 years, it's 60%. So young population and adolescent as well. So tending towards drug abuse and all sorts of issues. In such a scenario, and since last 7 decades, the health has been getting below 1% of the GDP. 2% is coming from private sector, but 1% is from, so it's total 3%. But if WHO says 3 to 4% for public sector, so it's so we are very, very short of those. So that has led to multiple challenges within the health sector, communicable diseases, now NCDs, and now mental health, a huge treatment gap for mental health issues. We have very few institutions. So doing away with institution, it's not a big, because we don't have such big institutions, very few. We have tertiary care hospitals where mental health, smaller units are there. Almost for 260 million population, around 1,200 to 1,500 psychiatrists. So you can well imagine. 60% of population in rural areas. So And now we are facing IMF as well, climate change as well, and the recent crisis within our area further damaging. And almost World Bank status says that 38% of our population lives below poverty line. So this is the dynamic, and that's what leads to the poor families into more challenging situation. So, but few good things have happened as well. Since 2014, I attended at AMRO, WHO, mental health framework was shared. NCDs was separate, but mental health was separate. So that was a starting point when they split it deliberately, that to keep mental health on horizon of the policymakers and all that. So from that, there on, we started off our work and technical working groups for mental health, and then we included priority mental health conditions within the essential package of health services, the DCP3 thing. Then we included mental health separately as a separate pillar within the National Health and Population Policy now, which is for the next 10 years, just to embed and stabilize it over there. But then there was a strong feeling that mental health challenge is such huge and with such a huge treatment gap, so it needs a policy document to move ahead within this status. So deinstitutionalization, not simply mean closing. We have very few. From custody to community, I think this would definitely take time. The physicians and nurses and all those healthcare providers, they need to be trained. We are not developed nations like in England or somewhere else. The very strong community networking is there, and they are taking care. But definitely with very few hospitals, very few physicians, so with then a huge treatment gap. So patients are mostly at their homes, within their families. Very critical cases they are dealt with. So we are trying to focus on integrated health services provision if we have sufficient fund, and then if the health sector totally is getting 1% of GDP, so how much the mental health would be getting within that. So that's a big challenge for us. So I've spent almost 35 years of my life in this public health domain, and so let's see the silver bullet as well, a silver lining as well. So first, mental health will be embedded. It has been embedded within the primary health care now, and there's a lot of support. Then the policy, why we need it. Second point is that we are moving towards a continuum of care across the life course. This includes community-based services, school mental health platforms. We have started off trainings of teachers as well, and then lead health. We have a large segment of lead health workers within the community, so covering around 60% of the population. And then integrating into general hospitals and strengthening referral pathways. So we have a network of primary health care, so they can, if the physicians are trained. We piloted MH gap training way back in 2016-17, and it was successful, but definitely it needs scale up. And the only aspect we can scale it up is we implement the essential package of health services in an integrated manner, in which all these priority illnesses are there, and it's well funded and well resourced. So that's how we think. And then thirdly, task sharing and non-specialist delivery model are critical, because without that, we won't be able to take care of our sick and who need such. And these are those which put immense burden on their families. They are breadwinner, and then if they are out from the business, so whole family goes out. So not everyone in our part of world, they work. The ladies, they are at their homes and taking care about the families and children and all that. So people with lived experience and families must be active partners in designing services. So human rights principles require that services are built around dignity, autonomy, and participation. And finally, deinstitutionalization in Pakistan must be contextually adopted. We are not replacing institutions because we have already very few with service gaps, and we are replacing them with accessible, person-centered, and community-based system of care. So mix of primary health care, community-based services, and then training the workforce, essential workforce nurses. So the goal is that not fewer buildings. The goal is more lives supported within the communities. So that's I think, if I'm able to address your first query. So this is the status, and that's why we are now thinking of having the mental health policy in Pakistan. So that at least, and as Senator was saying, that a lot of politicians have this problem as well. They are great stress. It's across the spectrum. You name and they have. So this is the status. Thank you.
Thank you so much, Dr. And I love that you brought up the importance of lived experience, because our final segment will be about lived experience. But before I go to that, and apologies for cutting the roundtable short in the interest of time, I did want to give the floor very briefly to Deborah also, because the WHO are about to produce an incredible resource on deinstitutionalization, and I don't know if you want to speak about it briefly.
Yes, thanks, and maybe I read, so I'm shorter. And the guidance is coming. You all know we have the WHO Global Action Plan, we have Quality Rights Initiative, we have resolutions, of course, the resolutions, but also technical documents produced in collaboration with the OHCHR, and what we have built, and then we have growing our work and commitment with having people with a lived experience as a meaningful component of the work that we do. Mounting on all this is that we are developing this guidance on the institutionalization, and we are working with a very extended network to make sure that represents and that becomes a practical and useful tools for all those member states and partners in general, civil society, people with experience that want to see a change. We try to make it a practical tool that is how, I mean, this is one of the most complex processes that one could imagine on transforming a system, as it was explained earlier. So what do we need to look into? How to assess the system, how to develop realistic transition plans, invest in meaningful community-based services, work with the workforce, as it was mentioned earlier, and then, of course, protect against coercion and listening to the people in those institutions and in general to understand what is the best solution for them. They are coming up soon. I'm looking at the main responsible for this, that is Mark sitting there, and yes. But what we know is that, okay, with that, hopefully, it's a concrete tool to be used. We dream that a leader in a mental institution or in the Ministry of Health or anywhere sitting in any country looks at it and says, okay, I want to lead this. What do I need to do? How do I engage others? But obviously, this is not just the work of the mental health sector, mental health professionals or mental health advocates. It requires broader, and it was again mentioned before, political leadership, investment and coordination across different sectors: health, social protection, housing, education, employment, justice, and many others. So we hope that we will make noise, maybe with the help of our colleagues here united, to make us disseminate it properly, and that everybody will enjoy working to change the life of people living in institutions and those who potentially, if there is no proper system, would end up in institutions. Thank you.
I think with that, in the interest of time, we will call the roundtable to a close, but I would love for you to give a quick round of applause again to this second panel and for their excellent intervention. Big thank you, Dr. Safi Malik, Dr. Marcello, Deborah as well, and of course, Senator Amira for your contributions. We began our conversations with international resolutions. We then grounded those discussions in the practicalities of deinstitutionalization. We are now going to go a step further than that and bring you the expertise of experience to really emphasize why human rights are a crucial aspect of mental health and why care, not custody, is the right way forward. And you will get to hear also from some of the people that you saw in the video, but also some other very incredible people. It is my pleasure to introduce Matthew Jackman. He is an expert by experience. He's a member of the Expert by Experience group of the Global Mental Health Action Network on deinstitutionalization, and he hails from Australia. We have Tiva Ayeni, who you've heard from already, but she is also a member of our Expert by Experience Action Group on deinstitutionalization, the Global Mental Health Action Network. And lastly, you will hear from Peter Varnum, who is the founder of the Brain Health Collective and co-founder of Global Mental Health Solutions. But perhaps, Matt, you'd like to start and take the floor. Share your story.
Thank you, Ali. Yeah, good afternoon, distinguished guests. I'm going to try and channel some of Devorah's passion and emotion. Yeah, I obviously come to this space as someone that's had lived experience of psychiatric systems and institutionalization, someone that's been a caregiver and someone that's been a child of a parent that's been institutionalized. So I'm going to try and bring in some of those other voices that I've been touched by as well as my own story. I grew up around a lot of child abuse and neglect, a lot of family violence, lived in poverty and was in and out of foster care during my early childhood. There was obviously a lot of profound trauma and grief, and then as an adolescent was dealing with my sexuality at a time where there was no mental health in schools or not a lot of literacy and support at that time. Much of those experiences of distress were later psychiatrized as bipolar disorder, which for me that experience was a deeply human response to what I'd survived, having issues with my mood. I first experienced institutions through my mother. She lived with deep distress and lived through domestic violence and a lot of the other conditions that I mentioned, and was abandoned and isolated by her parents, raising 3 children at a very young age. She'd had all 3 of us by the time she was 24. Due to all those, again, social circumstances and suffering, was branded and labelled with borderline personality disorder, which is a very common gendered diagnosis for a lot of the experiences, very human responses to the world that she was living in. She was discharged from psychiatric care without any meaningful support. This is at a time where we were deinstitutionalising in the 90s in Australia, but one could argue, that we've reinstitutionalised and institutions exist in the community through expanding forensic services, care homes, and that's another issue that's very important to talk about. But she suicided a week after being discharged from hospital, and my last memory of her is visiting her in a psychiatric hospital at the age of 9. I've also watched my younger siblings labelled by the system with chronic schizophrenia move through forensic psychiatric systems without any real genuine hope, healing, connection, dignity or recovery for their lives, very much discarded and dehumanised and seen as people that are terminally ill and can't get better. I myself have spent over a year cycling in and out of psychiatric institutions during the time that I've known Devorah over the last decade or so, and often again in response to trauma and distress as a consequence of a lot of the issues that I was going through growing up. I was often contained, then understood, managed, then healed. These places strip you of your identity, your clothes, your shoes, your belongings. They're unsanitary, they lack warmth, cleanliness. There's often dirt, blood on the walls that are left for weeks, months on end. So across these experiences are the stories, of course, not just of myself, but of many people. And I work as a social organiser in lived experience movements internationally. And I hear a lot from psychiatric survivors and users that are
heavily sedated until they can't think. Some people even suicide as a consequence of being cognitively restricted in hospital. These are stories that happen. The stories, of course, of restraint, seclusion, institutional trauma, and when suicides happen on the ward, we're told not to talk to one another. We're kept in silence and we take on the shame of the system. So I also remember working myself as a provider in a forensic hospital when I was very young, and we had a young girl secluded for years. She's 22 and she suicided. You know, imagine being a young person being secluded for years on end every day. This is every day. So we must also acknowledge other issues like unmodified electroshock therapy without anesthesia, which still happens around the world. It's torture. This is torture. You know, mad people with mental health issues are viewed as subhuman, and this is a problem in society. I can remember being threatened with involuntary treatment, you know, unless I voluntarily admitted myself or agreed and complied with what was required of me. And these environments were, of course, with many other people in distress, chaotic, unsafe, and often re-traumatizing. I can remember wailing and screaming that took me back to a lot of childhood trauma and reminded me of my mum going through her distress. And all the nurses could do was give you medication and say, "I'm sorry, this is all we have to offer," you know. So when I speak of mental health systems, I speak about systems that profoundly shape whether we live, die, heal, or become further traumatized. And I know my story is not unique, as many people labelled with mental illness are often surviving, as we've heard, you know, trauma, racism, colonisation, war, poverty, all these political and economic issues that often get psychiatrised and medicalised as individual suffering when they're deeply political. At the same time, governments are increasingly responding to distress through policing in many parts of the world. We only need to look to Donald Trump, where, you know, there's a lot of discourse around reinstitutionalizing unhoused people with mental health issues and people that are using drugs. And that rhetoric is weaponizing our community. So we must be honest that involuntary or non-consensual psychiatric practices are a profound human rights issue and one that's often not talked about in human rights discourse. So this is why conversations for me about abolition, because that's what it is, abolition of institutions, must include psychiatry and reforming carceral psychiatry. Abolition's not just about prisons. We can learn a lot from prison movements, but it's about dismantling systems that are based on punishment, control, surveillance, and the policing of human difference and diversity at the end of the day. A lot of my PhD work is interviewing lived experience activists around the world, and you know, they repeatedly say we're wanting to work towards alternatives to coercion, a world where we're not policed, a world where we feel we have relationships, peer support, mutual aid, and how, you know, things like housing, education without discrimination. So for me, these are fundamentally both a human rights and a social justice issue. And we, you know, alternatives, as Devora, you know, has done amazing work. Alternatives exist around the world to hospitals. People say, oh, well, what we do with people that are in severe distress? Well, there's crisis houses, soteria houses, peer respites, mutual aid networks, hearing voices networks, many of them peer-led, but many of them rights-based and in the community. So in many ways, we need to be scaling up things that are working, things that are being driven by people with lived experience and expertise. So just finally, I really urge, you know, member states, global health leaders, UN agencies to think about moving beyond coercion and moving beyond tokenism and being led by lived expertise as another discipline and form of knowledge that's just as valuable as medicine and psychiatry. And that needs to be centred. Those closest to this, you know, the problem are the closest to the solution. We need to recognise that there can't be any meaningful mental health reform without confronting also the issue of saneism, which we never name, which is psychosocial or emotional mental ableism in society. We name racism, homophobia, sexism, but we don't name the oppression. We call it stigma or discrimination. So for me, it's very important we start naming this as a form of oppression. And obviously, you know, we need to be addressing the carceral logic and mindset of these institutions and the people that work within them. As our visions aren't just about the absence of harm, they're about the presence of community, dignity, interdependence, healing, and ultimately liberation. Many of us in lived experience movements seek, a revolution. We require a revolution, and these take the right kinds of reform. Abolition is the right kinds of reform. Things don't happen overnight, as we know. But we need to abolish carceral and involuntary psychiatric systems, which include institutions, but also address a socially just society where people with lived experience are equitably accepted, understood, loved, and compassionately cared for. And I want to leave you with this, because I think a very common theme, even in my research, is dehumanization. People feel dehumanized. So despite that dehumanization of Madison society and the mental health system, I want to remind people we're not subhuman, even in extreme and altered states. We're people, on a spectrum of human difference and diversity. I'll leave you with that. Thank you.
We're running very short on time, but we do want to hear from everyone. So Tiva, back to you.
14 months. The first person who wished me a happy birthday on my 17th birthday was a member of staff watching me sleep. Every time I speak about my time in hospital, I feel the need to make a disclaimer that it wasn't all bad, that there were people who cared, that we laughed and we played games, because we did. But whilst we were playing cards, a 13-year-old patient was repeatedly banging her head against the wall for longer than we have all been sitting in this room today. 8.4 million people. Numbers that large can become almost impossible to emotionally process. We hear statistics and eventually they stop feeling human. So today, rather than attempting to speak about millions, I want to zoom in on one person. I have 5 minutes to try and show you what institutionalization can actually feel like. I've decided to share one story with you today. By this point, I had been in hospital for around a year. I knew the staff, I had formed close friendships with other patients, and in a strange way, hospital had become my home, a regimented and restrictive home. But at that point, I had spent over 6% of my life there. One thing, which is more than the 2% that is dedicated to mental health, one thing I'd always made clear was my desire to be kept informed. I'd previously been transferred suddenly between hospitals, and the experience had deeply distressed me. On this particular day, something felt different. The atmosphere shifted, and I was repeatedly reassured that nothing was happening and not to worry. Then suddenly I was told I was being transferred to another unit. I remember repeatedly saying, I am calm, please just let me walk. They told me secure transport was waiting outside. I looked over and saw a group of people, mostly adult men, wearing gloves and prepared to physically restrain me into the vehicle. My immediate thought was simply, let me just pack my things. When you first enter hospital, you are not expected to stay long. So I'd arrived with very little, but a year later, my room had become filled with paintings I had made, stuffed toys, and small pieces of comfort and identity. I then saw my belongings being placed into black bin bags. They walked me outside, holding both my arms. I think they expected resistance, but I've simply never been an aggressive person. I simply wanted to walk out with dignity. When we reached the secure ambulance, I asked, please, can I just sit in the middle with you? You can see that I've been calm. Instead, they placed me in the caged section at the back. If you take one thing from this speech, I encourage you to search what the inside of a secure mental health transport vehicle actually looks like. In that moment, I felt like a criminal. Except I was a 16-year-old girl wearing Crocs and holding an orangutan stuffed toy. I will never forget the feeling of sitting alone in that cage, watching my life packed away in bin bags. It's interesting that I have many different difficult memories from hospital, being restrained for hours by multiple adult men, being injected with sedatives multiple times a day, but this memory sticks with me the most. So when the Human Rights Resolution speaks about people being treated with inherent dignity and individual autonomy, it just feels so far from reality. Please, as we stand or sit here today, and I am speaking to you all articulately in my yellow cardigan and my ballerina pumps, remember that the Tiwa that I am describing was 6 years younger than the person before you now. What I found the hardest, perhaps, was that I didn't know how to live when I left hospital. The discharge that everyone talks about, a celebration, a new chapter, but what about when that is plagued with flashbacks and nightmares? Trauma responses like I was a veteran, but what I was, a 16-year-old child on a children's mental health unit. I had to relearn independence. I had regressed socially. Eye contact became very difficult. I only got through that because of my family, but so many people don't have that privilege. If institutionalization can have these effects within a high-income country like the United Kingdom, we must seriously question systems around the world that continue to rely on institutional and custodial models of care. We call these places hospitals, but simultaneously use terms like seclusion, segregation as interventions. Again, to put the humanity behind these words, seclusion is being locked in a small room alone, and segregation is when you can only stay between specific parts of the unit. What does that remind you of? When it comes to this topic, I believe the only excuse is ignorance. Generally, if you or a loved one hasn't been in a mental health hospital, you almost have no reason to know the ins and outs. But unfortunately, or unfortunately for you all, you are here today, you have heard from us. Let us remember that nobody is immune from reaching sudden mental health crisis and requiring hospitalization. It could happen to literally any of us. Let's not wait until a situation before we act. As members of the EEAG, our group of advocates from all over the world, we are here to support your countries and to offer our insights. Use us. The WHO used us for the DI guide. Use us. Finally, this isn't about me. 16-year-old Tiwa, 63-year-old Janet, 40-year-old Olu, and believe it or not, 8-year-old Aisha. There is only so long that we can shut our eyes to this issue. Thank you very much.
To close the session, but before I close the session, there will be refreshments outside and opportunity to network and engage. But our last speaker of the day to close the house is Peter Varnum. Over to you, Peter.
Thanks, Ali. What an act to follow. Thank you, Tiwa, for your story and for your bravery. It's great to be here with you and you, Matthew, and all of you in this room. So I founded a company called Brain Health Collective. We do lived experience engagement as a professional offering, but this is, of course, a personal issue for me as well. And I've done a lot of work in spaces like these and haven't had a chance necessarily to share some of my own story and motivation, but it is there. I have been hospitalized in 4 different occasions in 2 different countries. I've been strapped to a bed to try to sleep, which is unhelpful when the thing that can help you to get better is sleeping. I have been in a room for 2 days in solitary confinement, being one of the people who's banging his head against the wall trying to get out. And some people might think, well, okay, I would never go that far gone. I would never become that crazy. But I can tell you that if I wasn't in a room confined and solitary, then I certainly would have been trying to get out of there because I wouldn't have been in there. So I know what this is personally, and it certainly informs the work that I do and the spaces that I've occupied over the years. And I would just remind all of you that these stories that you're hearing today are proof, they're living proof that mental health is not predetermined. It does not determine anything. People can get better with care. These human rights violations that you've heard about and the work of deinstitutionalization are so important to address because it allows for people like us to thrive. And I think you're exactly right, Tiwa, that this sort of thing can happen to anybody. So This is an issue for all of us. If you met any of us in a setting that wasn't a professional setting, you might not understand, or you might not consider that we've gone through some mental health challenges. We hear a lot about this idea, and it's in the literature, of social contact being the way that people change their minds about things. And this is, just hanging out with other people who might challenge your perceptions of what you had believed before. I think this is really, really important when we're considering the brass tacks of what actually happens during deinstitutionalization, and we speak about lived experience engagement and empowering people with lived experience and young people. Imagine that you're one of these directors of a psychiatric hospital who's worked there for 25 or 30 years, and somebody who has been within your hospital for that time is then supposed to help you figure out how to transition out of it. That is awkward, to put it lightly, but it's so important. Those people who have experienced what that is like in those institutions need to be there to co-create what it looks like to transition out of them. They need to be there to design the care pathways that people like them would have liked to have experienced before. So go back to your countries, to your institutions, to the organizations that you're affiliated with, and embrace that kind of awkwardness. Make sure there are people like us everywhere. We're privileged and lucky to be in rooms like these, but we're everywhere. So find them and work with them to be sure that we can create a future that is allowing people to thrive, and one that is full of care and not custody. The last thing I want to say is our advocacy and the skills that it takes to do this advocacy. They're skills that we have built up, but I know these individuals and others. There are professional skills that translate in spaces that are not focused on advocacy, right? So more people with lived experience who know what this is like, more carers who are in positions of power, who are in positions of leadership, who can bring this sense of empathy along with this giant toolbox of professional skills with them is really critical. You're going to keep hearing about people like us because we won't shut up, one, and because also stigma is decreasing, which is positive. So if you're in positions to hire these people, if you're in positions to promote these people, if you're in positions to allow them to speak at engagements like these, please do so. Thank you to folks in this room. And finally, I'll just give a huge thanks to Ali and Khaled and United for Global Mental Health and OHCHR for hosting this event. The work is not done, it's in front of us, but we have support in the room. Thank you very much.
Thank you so much, Peter, Tiwa, and Matt. And with that, we're going to close this discussion, but say that the discussions continue. And one way that they might continue is you might see Dave Gill in the corner there of the room. He's recording pieces to camera for people that want to talk about deinstitutionalization or mental health and human rights and about their work. So if you're passionate about the subject and still want to talk about it after this session, please find Dave. Thank you. Have a lovely evening. Thank you so much for your time.